So it seems to be okay. Right, shall we get started? Okay, so just to begin with, we're just going to do some virtual housekeeping. So welcome everyone. We were so lucky. We had nearly 200 people actually register for today's event. So I also know that lots of people will actually be watching the webinar later on. So we will definitely share this along with anyone who couldn't actually attend for this evening. So in terms of kind of what we've got planned for today, essentially we're going to make sure that you get an opportunity to look at radiotherapy. What we want to make sure is that you can't turn your cameras on because we are recording, and also there is the chat function. So if you look in the bottom right hand corner, you will see that that is available to you. So please do have a look at that functionality. Obviously we're all professionals, so it's just being courteous within the chat function, and also making links and networking I think is really important. So I'd like to start by introducing myself. So I'm Jo McNamara. I'm a therapeutic radiographer by background, and I've actually been qualified now 17 years, which makes me feel really, really old. I am a senior lecturer at Sheffield Hallam University, and a year and a half ago, I was actually the National Macmillan Clinical Fellow. So I did that role for a year to promote the role of therapeutic radiographers, but also promote radiotherapy. And that's obviously what led me to then get to know Naaman. And Naaman and I co-host the Rad Chat podcast together, and we also consult for some of the charities. So I'm going to hand over to you, Naaman.
Thanks, Jay. Thanks everyone for coming. My name's Naaman Joe-Canson. So I'm a senior therapeutic radiographer, but I specialise in treatment review. I haven't been working as long as Joe has, but there we go. So I do quite a few things, same as Joe does, around Radiotherapy UK, the charity, Move charity as well, and we're both STEMnet ambassadors. And yeah, I'm leading some skincare research for the Society College of Radiographers.
So we're going to hand over now to Sue, if you'd like to introduce yourself.
Hi everyone, I'm Sue. I can't even pronounce my surname properly myself, so we'll just leave that one there. I'm a therapeutic radiographer by background as well, but there it says senior dosimetrist. Essentially that job title means dose maker, so it's my job to put radiotherapy treatment plans together. I've been qualified for 11 years, travelled around a little bit across various sites, worked in the NHS, and now I work for Genesis Care. So yeah.
So I'd like to hand over now to Tara.
Hi everyone, my name's Tara and I help out with Rad Chat behind the scenes with their podcast and their social media platforms. Background is in biomedical science. I've spent the last 8 years or so working for a handful of different companies around cancer diagnostics, and I decided I wanted to bit of a career change, working more in a patient-facing role. So I'm now retraining at the University of Suffolk in therapeutic radiography.
Thank you, Tara. Handing over to Will.
Evening, everyone. I'm Will Kinnaird. I'm a therapeutic radiographer too. I work at University College London Hospitals. I'm in a prostate specialist role, and at the moment I'm concentrating on urology research and development. I've got particular interest in sexual dysfunction as a consequence of prostate cancer treatments, as well as advanced prostate cancer. And yeah, I'll be helping out with answering questions and things. So yeah, please feel free to put any questions in the chat.
Oh, thank you so much, Will. And it's great to have everyone join us again this evening. And thank you so much to our co-presenters for giving up their time for free to come and help do this. So why are we doing the webinar? Well, essentially, through the podcast, we heard repeatedly from patients that they felt that they weren't necessarily prepared for radiotherapy. So we feel it's really important to help raise general public awareness, but also a multidisciplinary team. And potentially, you know, we might start a series of these webinars to share professional insights into how we may be able to help support patients. So we're going to go through what radiotherapy is, how it's used, some of the processes. We want to give you some real insight into what a patient experiences. So when you are talking to a patient about their cancer pathway, you can empathize more, but also get a real insight into what it is that they've had to endure, really. We are going to use some radiotherapy case studies, and also we will of course cover some of the side effects of radiotherapy, which sometimes are underestimated and also undetermined, along with other side effects from other cancer treatments. So moving on, I just want to briefly highlight some of our contact details. So we are on social media, so please do take a look. The reason we're promoting our social media is because actually we've got lots of videos, lots of content that can actually also help educate you about what radiotherapy is. So please do have a look. TikTok, we're still quite new at, largely because I'm old. Tara is so going to be all over TikTok, I'm sure. But essentially, it's a great way for us to share really quick snippet videos of what it is that patients are going to go through, and also what it is that you can expect as a healthcare professional working within oncology. Okay, so the typical oncology pathway. So many of you are experts in your field. You know inside and out the oncology pathway. Radiotherapy specifically can be used across the oncology pathway and may be used prior to surgery, post-surgery to mop up any cancer cells, any iatrogenic spread. It can be utilised adjuvantly or concurrently as a way of radiosensitizing cancers. And so it's also worth considering where in the patient pathway they may be having radiotherapy. Now, actually, according to Cancer Research UK, who recently did some research with Cardiff University, nearly half of people who had potential cancer symptoms in the first wave of the pandemic didn't contact their GP. And we've seen this visibly within radiotherapy at the moment, with later stage cancer patients coming for treatment. And so actually what's representative of where radiotherapy features for some patients now isn't always representative of what hopefully will happen in the future, and also what was happening pre-COVID. So an interesting statistic that I also like to highlight when I talk about the oncology pathway is the role of the GP. So the GP essentially sees hundreds upon hundreds of patients, and I've read it in numerous times in patients' notes whereby patients maybe haven't been diagnosed as a result of the GP not referring. And I think a statistic to bear in mind is the fact that the average GP will refer only 8 patients who go on to actually have their cancer diagnosed. So that could mean that obviously there's a larger percentage now going through A&E, but I think it's important for us to recognise that those people working in primary care have a huge caseload, and cancer is part of that, and it's just worth bearing that in mind, really. So I had to and couldn't not go through some history. Who doesn't love a bit of history? So on the 8th of November, which is World Radiography Day, in 1895, Wilhelm Röntgen discovered X-rays in his German lab. So that first X-ray there that you can see is of his wife's hand, and he was obviously awarded the Nobel Prize for Physics in 1901. So in 1953, we saw the first medical linear accelerator being used, which you can see there. And then in the early 1990s, with the involvement of CT scanners and computers used for complex radiotherapy planning, we saw the more sophisticated and common looking linear accelerator coming through, which you can see in the top right-hand corner there. Then we had a huge shift, and that was largely as a result of the development of multi-leaf collimators. So in the middle there, you'll be able to see, just ever so slightly, I'm sure Naaman might use his cursor just to ring round it, lots of tiny little lead leaves. And essentially they're like fingers that are going inside the head of the machine and can personalize shapes. And that allows us to then actually affect the dose that we're able to give the patients, but also conform very nicely to a tumour or where the tumour was if they've had surgery or chemotherapy previously, and therefore save some of that normal tissue. So as we go through and look more in the modern day of radiotherapy, next slide please, Naaman. We see that actually technology and software development is huge. It's such an exciting time for us in radiotherapy, but it is also imperative that we stress that actually the NHS can't keep up with the cost and infrastructure needed for these ongoing advancements. And so, you will find that different radiotherapy centres have different equipment, different software, different processes, and that's because there isn't any, as I'm sure anyone who works for the NHS will know, there isn't any standardisation of radiotherapy. We try very hard from a manager's and also from a therapeutic radiographer's perspective, but ultimately some departments will invest in their radiotherapy centres more than others. So it is just worth bearing in mind that as we talk about radiotherapy, there are departments that will have different pieces of kit and different software, which might allow differences within the radiotherapy that's actually delivered. So in the top left-hand corner there, you'll see an MR Linac. So as the name suggests, it's an MRI scanner and Linac all in one. So it's really advanced and sophisticated. It allows soft tissue imaging and actually allows more accurate radiotherapy planning and potentially more adaptations in treatment throughout the course. So as tumours respond to treatment, we can then use the sophisticated imaging to replan. You'll then see the protons. So this is a proton machine here, and essentially protons are positively charged atoms, and they release their energy only after travelling a certain distance. So they won't penetrate straight through the body like photons, the X-rays that we use in radiotherapy. So that makes them good at damaging cells at the end of their path, and that means that essentially we are damaging less cells and less of the normal tissue. So proton beam radiotherapy is largely used for paediatrics in the UK, and it is used for some more complex tumours that are next to very dose sensitive structures, organs of risk, but there are more studies needed to look at the long-term implications of proton and also using it for other treatment sites such as breast. So it does require the highly specialised treatment. It's not widely available, although it is more available within the private sector. If we look then on the top right hand corner, you'll see a CyberKnife. Now I've seen CyberKnife in action and I have to say it's absolutely amazing. Anyone who's on Instagram, if you follow Bow Babe, you may have seen that she actually had CyberKnife treatment, and it is like a robotic arm that essentially will track the tumour and move as and when the patient moves, so that it's just treating very precisely within millimetres of accuracy the tumour. You'll also see below that an Elector Gamma Knife. So that's essentially called something that we refer to as stereotactic radiosurgery. And that's actually where a radiation source is used to treat brain lesions. So stereotactic radiosurgery is not necessarily just limited to brain tumours. So I've seen arterial malformations be treated, acoustic neuromas, so it can be utilised by therapeutic radiographers for other conditions. It is worth noting that it is very different in the fact that you do have to have a metal frame fixed to the cranium, and then you go into the machine where the source is actually positioned. So very different to anything that we kind of see in terms of radiotherapy. So that leads us on to what is radiotherapy? Well, radiation used for cancer treatment is called ionizing radiation because it forms ions, and essentially they're electrically charged particles in the cells, and it passes that energy as it progresses through. So it can create ions by removing electrons from atoms and molecules, and that means that it can kill the cells or change the genes so that it actually stops growing. So we get photon radiation, which is X-rays and gamma rays, but we also get particle radiation as well in the form of electrons, photons, neutrons, some carbon ions as well, which again you may see and hear more of in some of the kind of more advanced radiotherapy techniques. So some types of ionizing radiation have more energy than others, and the more energy they have, the deeper they penetrate the tissue, and that's where essentially we can get some of the dose and fractionation regimes, but also in terms of the intensity of the beam that we're actually utilising for our treatments. So moving on to how radiotherapy works. So radiation destroys cancer by depositing high energy radiation within the cancer tissue itself. And over the years, radiation therapy has been driven by the constant technological advances, and that's within the equipment, but also the research around radiotherapy as well. The biological effectiveness of radiation depends very much on something called linear energy transfer. It also relies on the dose, the number of fractions. So when we say number of fractions, it's essentially every time a patient has radiotherapy, we call that a fraction of treatment. And also the radiosensitivity of targeted cells or tissues. So for anyone who is a biology geek like me and wants to learn more, then actually if you refer to the Rad Chat podcast, we've just produced a podcast series called What is Radiotherapy? And the latest one goes into skincare and also some of the radiobiology. So if you want to proper geek out, definitely go and check that out. Because of the radiobiology, we can't deliver a radiotherapy dose typically within just one treatment. So that's why patients have lots of radiotherapy appointments. Essentially, what you don't want to do is cure the patient of cancer using radiotherapy, but then also, their quality of life be impaired because you've damaged so much of their normal tissue. So some patients may have 8 weeks worth of treatment, whereas some palliative patients may just come for one single one to try and relieve symptoms, whereas some patients may actually have multiple treatments within a day. Now, if that does happen, they do have to have 6 hours apart because that allows what we call the therapeutic window to be utilised. And that means that normal cells are able then to repair themselves. So I'm not going to go into mitosis and the whole cell cycle because some of you might get bored and decide actually now's the time to leg it. But as I said, please do have a listen to the latest Rad Chat podcast. So just looking at the use of radiotherapy, some interesting stats, I won't read them out, but I think it is fair to say that in the UK, radiotherapy is an underutilised form of treatment for cancer. It's actually one of the cheaper treatments, and actually with more advanced techniques and software, we should be able to use it much more effectively for a much wider demographic of patients that we actually do. So when we look at treatment modalities, it's normally when we talk about radiotherapy, we refer to it as something called external beam radiotherapy, but it is worth noting that there is also something called internal radiotherapy, brachytherapy. And so we don't have time to go into these today, but again, that might be content for another webinar. But you will see that I've kind of mentioned them, and there is a diagram there of showing some cervical rods that are used as part of brachytherapy, and they're using radioactive sources. So as I said, we don't have time to go into it, but it is a really interesting topic, which hopefully we'll go through at a later date. There are the radioisotope injections, so typically used to treat cancers like thyroid cancer, and then intraoperative. So that's essentially where electrons are used at the site of the tumour during surgery. So when we look at intent, so why are we using radiotherapy versus maybe some of the other treatment? Well, I think the first thing to note is that actually it is really highly effective. It can be used curatively, but actually it's really good to alleviate cancer symptoms for anyone living with cancer and maybe having palliative treatment. So it can ease things like pain, bleeding. If you had a fungating tumour, it can reduce it. And actually, this isn't the scan of a patient, but it's a very typical example. So I had a patient who presented with hemoptysis. They were really struggling in terms of general malaise. They had weight loss, and so they got diagnosed. They had a mesothelioma tumour, so you can just see it circulated there on the scan. They had radiotherapy, and then 4 weeks later, you can see we were able to shrink it to such an extent that actually they felt a lot better and didn't have any symptoms anymore. But actually we didn't get rid of it totally. And we knew that on the outset. Unfortunately, the patient did have brain metastases already, which means that parts of that tumour had broken off and then gone into that patient's brain. But we knew that we were able to make that patient feel much better and improve their quality of life. So it is important to think about the intent and when we might use radiotherapy. So looking at the linear accelerator in all its glory. So this is kind of what you came for. What does it look like? What do the patients have to endure? And I think one thing to bear in mind that the linear accelerators are massive. So I still remember to this day walking into a radiotherapy treatment room and I gasped because I was like, oh my gosh, this looks new age. It looks very scary. It's massive. And I'm just this tiny little thing lying on a treatment couch. So it can appear really daunting. So trying to prepare patients as much as possible is really important. You'll also notice as well on the image that there is a tiny square that shows some what we call applicators. They're essentially what attach to the machine and actually convert the photons, so the high ionizing X-rays, into electrons. And electrons are great because they don't penetrate deeply into the body. So it can be used to treat the skin, it can be used to treat fungating tumours or lymph nodes that are very close to the surface of the body. So what does the patient experience? So before the patient can actually commence radiotherapy treatment, they need a CT scan. This is not the same as a diagnostic CT scan. We just scan where we're wanting to administer the treatment, and the CT scan must, and this is the key, must be undertaken in the same position that the patient will have treatment every single day. So we're using that CT scan to plan the radiotherapy treatment. So we need to make sure that when our patients come for pre-treatment, and that's what we call it, that they have that scan in the same position and we can reproduce it on a daily basis. Now, the CT scan itself takes between 1 to 10 minutes, but the appointment is usually much longer. And that's largely because of the immobilisation devices, positioning, and also patient information that we need to provide. So the next slide just shows a little bit about the immobilisation equipment that we use. Now, we treat within millimetres of accuracy. So for our patients, we need to make sure they're as comfortable as possible. If they move during their treatment, then we could have a potential miss. So that means that we may not treat all of the tumour, or we may miss it totally if it's a big, large shift. So immobilisation ensures accuracy and reproducibility on a daily basis. Now, physios, I know there are some in the audience, or there might be some that are listening. We need your help because typically we do treat a lot of breast cancer patients, and having good mobility really does help. Now, I know some of you are already amazing at being able to advise patients of the position that they need to get into, but that's largely probably because of the experiences that you've had or patients that you've seen that have talked about their radiotherapy experience. But it is a very different position compared to maybe some of the positions or exercises that you typically would get patients to do. So you will have patients in that position where they are having to have their arms above their head. Now, it's not a natural position, and actually even myself, and you know, I've done it as part of some research before, laid there on the bed for 20 minutes simulating that position, and it's hard. I do get pins and needles in my fingers. So, you know, if you've had a mastectomy or you've had a lumpectomy and you've got scarring, you've got pulling on the scar, the skin is taut, then essentially that can be really difficult for patients. So physios, if you can advise, share your learning, absolutely, it would be amazing to collaborate on things, because it definitely helps us as therapeutic radiographers get those patients in the right position. The same can be said for some head and neck cancer patients where they need to lie with their chin extended, and also for some of the lung patients as well, they need to have their arms up holding poles. So all of those positions can be difficult if a patient's had previous surgery or generally has poor mobility. So when we then do the CT scan and we know that that's the position that we want to reproduce every single day, we need to make sure that we have a point of reference. So to do that, we rely on tattoos. Now, they're tiny blue-black ink marks that are made on the skin. They are permanent. So you can appreciate that some patients do have a psychological lasting impact as a result of those tattoos, and that does mean that there are new ways of positioning patients without having to use the permanent tattoos, which I'll talk about in a little bit. It is worth noting that, as you can see from that image there, we're using laser lights to align with the tattoos every single day. And that's why typically therapeutic radiographers work in the dark. You know, when patients come in, we always say, how's the weather? Largely because we have no idea, because we're usually located lower down in a bunker and we are there in our very dark rooms using our laser lights to align with these tattoos. So patients can be exposed, and that's worth bearing in mind as well. There's typically 2 or 3 members of staff in the room. There would never just be one. We have to work together. Legally, we have that whole checking of each other's work. So we work always within a pair. If you ever wanted to go into the profession, you have to like working with other people. We are not autonomous on our own. We're always partnered with someone, especially early on in our career. So I'll just show briefly the surface guided radiotherapy. So this is thankfully an advancement in technology and software that some departments have. It's using 3D cameras to identify the patient positioning and actually can correct for positioning and won't allow the machine to switch on if that patient isn't in the right place. But that obviously negates the need for those permanent tattoo marks. So we then go on to radiotherapy planning. So once we have those CT images, they're then passed on to our planning team, and the amazing Sue is going to wow us all with those CT scans and what she then goes on to do with them. But what I would like to do now is actually share my screen, and I'm just going to share with you a video of what radiotherapy actually looks like. Can I just check that that is sharing correctly? Okay, thank you.
My name's Jerry. 4 years ago I was diagnosed with mouth cancer. At the time I didn't know what to expect during my hospital visits, so we're doing a short video today to try and put some people's minds at ease and show you exactly what happens when you have radiotherapy for head and neck cancer. I was diagnosed with mouth cancer, went to the doctors with a small lump in my mouth, and he sent me on for further tests at the hospital, and that came back within 2 weeks. Yes, it was mouth cancer. What you'll do initially, you'll come in, you'll have your scans done, you'll have a CT scan, you'll have a normal scan, then obviously they know where your cancer is, then they'll have the mask made, and then your mask is available for you every time you go in and have your radiotherapy. I've got mine at home. Some people want to keep it, some people say no, but I kept it. The purpose of the mask is you have to be kept still. The mask is clamped, but not in a horrible medieval type way. It's there so you don't move your head. Everybody's cancer is different, everybody is an individual. Some people are very nervous and some people just ride it like they're getting the bus home. But everybody I speak to at the end says it wasn't as bad as they all thought it might be. Anything you're not sure about, they want you to ask. So if there are any questions, just please ask a member of the staff, and they're so helpful. When they actually put the material on your face to mould it into the mask, it just feels warm, and it's actually not a bad experience, very much like when you get a heated towel if you're on a long haul flight somewhere. You just lie there and think happy thoughts. The mask is made for you, and then you have to wait just for the mask to set, etc. They will put a small dot, a tattoo dot on your chest so they can line it up when you go in for your treatment. And they put various pieces on there that they need for alignment of the radiation. It's over within a matter of minutes really, it's not a long drawn out process, and certainly not painful. You are put in the CT scanning machine. Now obviously when you're in the scan itself, all the staff have to come out of the room, but they are there and they do give you an emergency button to press. It's fairly open, you can see the machine working, and the machine actually sort of whizzes around, where if you look up you can see the lights whizzing. It's not a bad experience. It's very, very important with the mask when it's fitted to maintain the same weight. If you start losing weight, the mask won't fit correctly. Because at some days you won't feel like eating because of mouth ulcers and things. A lot of people will have a food peg put into their stomach. It helps you so much when you don't want to eat, to know you can just put your food through your peg. So I'm just back from having my mask all fitted for me, and that's gone upstairs with the technical team. They put all the bits and pieces together and tailor it all for your own special needs that you need for the radiotherapy. This usually takes around about 2 weeks, but it needs to be tailor-made just for yourself and each individual person. So I will see you at radiotherapy. The major concern for people that are having the radiotherapy is people feel claustrophobic with the mask being fitted. You can't move your head from side to side. You are restrained because you start moving, obviously the beams will not be hitting the space, so you have to be kept still. But it's important, once you get that first session out of the way, the claustrophobia, just, you don't really think about it.
Okay, Joe, if you're ready, here we go, okay? Here we go. There we go, nice and straight. Chin up a little. Excellent. Just hold still there.
Because you can hear people adjusting the machine, but obviously with the mask over you can't quite see, but they do talk to you and they do help you. They put your head in a nice position so you're comfortable. They always explain exactly what they're doing. They really are superb at their job, and have faith in them. The people that are doing the radiotherapy for you, they're on the other side. You're constantly on their camera, and while they're doing that, they're actually scanning you as well, and that is given to the doctor on a daily basis, so they can monitor how things are going with your radiotherapy. And again, if you need them, you can always wave your hand because you know they're constantly watching you.
Okay, Joe, I'm just going to leave the room now, so I'll be watching you all the time. All right.
See you later, Joe.
When I leave the room, the machine will start up. It is noisy. It's not horrendously noisy, but it does clank and bang about. But you'll get to know over a period of time, as the machine goes on, you'll get to know the sounds of the machine, and you'll actually know when you're coming to the end of your session, because you've got no concept of time.
Okay, so that's what it's like for some of our patients. Obviously, it is personal to everyone. I do know that he commented about it being like a warm flannel. I know some patients really struggle with the head shell, so it's just something to bear in mind that was very personal to him. But well done, Macmillan, for producing that amazing video. So the last thing I want to do, because I've taken up way too much time and I apologise, is just some of the terminologies, which I'm not going to go into loads of detail about because Sue is going to cover them. But essentially, radiotherapy techniques mean that essentially the radiotherapy that we're delivered is personalised for that patient. So some of the terminologies and techniques that you may hear about or read about in patients' notes are summarised here. We use acronyms for absolutely everything, and it's awful. When we do kind of interprofessional education, you just think, why do we use all these acronyms? Because it's a nightmare. But these are the kinds of things that you might hear. So intensity modulated radiotherapy, image guided radiotherapy, volumetric modulated arc therapy, stereotactic ablative radiotherapy, and deep inspiration breath hold. So I know Sue's going to cover a few of those, so you'll be able to see them specifically. But one thing I would like to highlight to you is the Respire project. So I know Will and Tara will hopefully share that, but that is essentially an interdisciplinary resource that's been produced by Sheffield Hallam University using patients to inform, but a amazing physio was part of that, a respiratory physio, to essentially look at how we can use breathing to hopefully minimize the dose to the heart and the lungs for patients having chest or breast radiotherapy. So I'm going to hand over now to the amazing Sue. I'm so sorry I talked for so long, but we all knew this was going to happen, so I'm sorry.
All right, I'm just going to pick up the screen share, hopefully pick up the right thing. There we go. That's a really nice segue, Joe, talking about breath hold, because the first case I've got is actually what we call a deep inspiration breath hold technique. What is it? What is it for? The main thing, as Joe says, is to try and spare the heart from radiotherapy, in particular for patients having radiotherapy to the left breast, chest wall. It's a technique that helps us. If patients are, for whatever reason, not able to do it, it's not the end of the world. So that's one real take home as well, is I've purposely picked an example to show you how drastic a difference it can make, because it has this good effect for the audience, so you can see. But there are other things we can do, and everybody's anatomy is so different. We've talked a bit about making sure everybody's in the same place every day, and it means outside and inside. So when we look inside the body, that's where my job comes in, because I start looking at these pictures all day, every day, and I sort of, just get used to it. But to orient you to what we're looking at the moment, for those of you who haven't seen images like this, it's a CT scan. computed tomography, which is basically a computer slice picture. That's how it translates. And I get so used to looking at people like this main image that we're looking at the center of the screen, and that slices through someone from top to bottom, like head to toe. And then at the side, we can do 3D reconstructions so that I can look at them front on and side on as well. And as Jerry mentioned in his video, he'll have his CT planning scan, and then it's a couple of weeks before he comes back for his radiotherapy. It's quite a difficult time for patients because we're busy working away in the background. It's quite hard to appreciate all of what's going on. There's a lot of checking as well, like Joe mentions in the treatment room, but we're doing that over a matter of days and hours, working very closely with the doctors. There's quite a bit of back and forth to make sure that we're happy with everything that's going on. So that's kind of all of an overview of what's going on with the radiotherapy planning. But for this particular case, coming back to breast radiotherapy, I've drawn around the heart. So this is one of my jobs, is to literally draw around all of someone's organs. It's actually quite therapeutic in and of itself. And yeah, we do that for all the different patients that come through, literally every single one, the various, what we call organs at risk, the things we want to avoid. So I've got the heart switched on here. And as I say, I've picked a classic example of the benefit of breath hold. This patient, as we see her, is in a breath hold. So she's taken a deep breath, and we required the CT scan over the course of about 20 seconds for this scan. When she goes on to treatment, she'll have to hold her breath for about 40 seconds if she can. If she can't and she has to breathe out, that's perfectly fine, because we can stop and start, and there's no worries there either. But the difference that it makes to where the heart is, so if you see where this red structure is now, and if I flick it back to, this is what she looks like when she's just breathing normally. And people might hold their breath when they go in for a scan, but maybe she's breathed out. But it's kind of a sort of a normal free breathing, as we'd say. And if I do the same on one of these other images, you can see them now there. Okay. So you can see the difference of sort of how full the lungs are between the two, but also where the heart's moving, and it's now sitting right up against the chest wall. As I say, this isn't classic for everybody. Everyone's different. I have no idea where my heart sits in relation to my chest wall. But the difference it makes when we do the radiotherapy plan is, and this is the dose now switched on. So these pretty colours are basically the radiotherapy dose. And this dark blue line is the sort of the edge of the field. So for this case, with the sort of the free breathing, you can see that the heart is getting some of that blue. And if I take it back to where the patient is in her breath hold, and we can avoid it completely. So it's really, really important. It's been a sort of big sort of point of research over the last sort of 15, 20 years, looking at the heart doses and sort of the late heart effects that women have from breast cancer radiotherapy. So simple as looking at sort of left-sided and right-sided treatments and how many cardiac events happen in either cohort. And so they've implicated a few different bits and pieces of the heart, and we do everything we can to avoid it. So that's that one. The other thing I did want to just switch on very quickly is this is a very, very broad example, but this is kind of showing where the machine would be. It's not that close to the patient, but this is sort of the angles that the machine would be treating the patient from to get this kind of line straight through her. And that's the angles that the radiotherapy would come in, and that's just for like this kind of treatment. As Joe says, everything's different for different people. It's all individualized, and the sort of the advantage, if you like, of trying to treat someone with breast cancer is that they're on the outside, like the breasts are outside the body. The main things we're worrying about is the heart, the lungs, and the skin as well. Does get a skin reaction, more on that later. But we don't have to try and get the dose like really central into the middle of someone, which has its own challenges. So I've got a couple more examples showing that as well. Someone having radiotherapy for breast cancer in this kind of situation quite often will have had, so this lady's had a lumpectomy. There's some little blue things we've drawn around, you can see. That's where her tumour bed is. So that's where like the tumour was, it's been taken out. So it's gone, you know, she's hopefully the cancer's gone, but we know that there is a benefit in having radiotherapy to come along and mop up in case there are any sort of stray cells. It's kind of like a just in case safety net. And it goes back to what Joe was saying about the different places that radiotherapy can be used in the cancer patient pathway. But something else I wanted to highlight as well is how we can use radiotherapy and what techniques we might use for someone who maybe had their breast cancer treated like this sort of 5-6 years ago. They go along merry on their lives, and then something happens and there's another, something has come up, a metastasis somewhere. Or sometimes people are on kind of long-term chemotherapy. Everything's well controlled, but we're seeing a situation now where sometimes they get these little mets pop up, and we call it oligoprogression, if I can say it properly, where they have these isolated or few metastases. And it's what we do, we can use radiotherapy to help with that, and almost spot weld, you know, we zap those tumours, and then nothing else will happen. We've got the problem, and they'll carry on living with cancer under control for X amount of time afterwards. So I mentioned that, and I'm going to bring up another picture now, because this is also a breast cancer patient, exactly that situation, going on for so long, and this tiny little thing, which is lit up here with a PET CT scan. If I just take that away, you can see there's hardly anything to look at. There's just a tiny little grey splodge, but it's shown there on the PET CT quite clearly. And this lady also had a type of very focused radiotherapy. It's called stereotactic body ablative radiotherapy, and the A meaning ablative means it's an ablative dose. We completely nuke that little tiny splodge, for want of a more technical term, and you can see how the doses are shaped around it. It's really sparing everything else. For something like this, we can do it in like 3 treatments, and it's a very high dose per fraction because it's such a small area and it's so conformal. And yeah, that tumor will die, and it won't come back. And you know, she'll carry on. She was on chemotherapy with other things controlled, and you know, we just wait and hopefully she carries on that way. So people are living with cancer for a lot longer. And radiotherapy has a role in that setting, as well as the radical setting where they basically have treatment as part of that initial pathway. So next up, I was going to talk about another sort of group we see quite a lot of, which is the prostate cancer patients. I have to keep moving my Zoom buttons around so I can click everything. Again, the colours here, this is a picture of the dose. I'm not going to focus too much on what we're looking at, but you can hopefully see that it's aiming for something in the middle. And here, this is where it gets a little more complicated in terms of what we're wanting to avoid, important things that are nearby. I'm going to switch that dose off. So the prostate itself is this blue, it almost looks like an upside down triangle on the one picture, and it's nestled in underneath the bladder. You've got the rectum just behind it, and above the bladder is where the patient's bowel is. So we come along and do radiotherapy to the prostate, and we're going to upset all of these bits nearby. So this is what we call the organs at risk. And we do torture our prostate chaps because we get them to come in and drink lots of water and hold their bladders, and we scan them. And we have to try and do this for every single treatment. And it might be up to 8 weeks of treatment that they have to do this same protocol. And the rectum as well, we want that to be a sort of a smallish size so that it's not getting too near the prostate. It's not going to be pushing things out of the way. Incidentally, this chap also has a little spacer in between, which is a whole other thing we've not spoken about, but it just gives us a bit more wiggle room to treat the prostate and avoid the rectum nearby. But yeah, we do that, and we get them to fill up their bladders, and they will have many stories about times that their bladder wasn't as full as it should have been. And these are people who already have bladder symptoms, and we are just making things that much more difficult for them. So this is, to say, the prostate plan itself. So the dose comes in and it moves around the whole patient, as we saw on the video. And to just bring it up a notch as well, sometimes we're also treating the lymph nodes as well as the prostate itself, and these sit up a little bit higher. So on the sort of the top right image, they're there as a sort of cream colored structure, and if I scroll through this one, see the prostate, and this is where the lymph nodes live, in this region here in the cream colored structure. And this brings even more challenge in terms of managing side effects. It's very important that the bladder is nice and full. If it's not, it kind of collapses down like a balloon, and what happens is the bowel, which is blue, drops down and gets that much closer to where the sort of the really high red doses in this case are, and we know that that's going to be causing them even more grief. So at this point, I'm just going to pause. I'm going to let Naaman take over and go through a little bit of a case study for a prostate patient. If he's poised, there we go.
Thanks, Sue. I'm sure you've all been mesmerised by the colours. I love planning, it's amazing. So just going to talk very quickly about a prostate patient. So similar to what Sue's talked about, we'll go back into kind of what's going on internally as well. He's an ex-Marine, one of my favourite patients of all time, I think. Just because I've been in the Army Reserve, I kind of understood where he was coming from. So prostate cancer patients, they'll get either 60 grey, they're in 20 appointments in total, or it can be a bit higher, about 72 grey in 32 appointments. So he had been 20 years in the Marines, only just left 3-4 months ago, diagnosed with prostate cancer. He's living alone. He drank, I think, about a bottle of wine a night, at least 20 cigarettes a day, and many wets, as he likes to call them, so coffees and teas, and he didn't drink much water. So we talked a bit about bowel and bladder prep, so that was already going to be an issue for us for him coming through. Lots of other things. I mean, cigarettes, we know that, from research why they're bad for you, but normal military behavior for him, so causing lots of antioxidants in the body, but actually when they start treatment, it can really irritate the bladder lining even further, and when it's already dehydrated, it struggles. Radiotherapy, which we'll show on the scan, Sue will show on the scan in a bit, but where we do start to deliver radiotherapy to the prostate area, it will start to swell, and obviously the urethra is going to be going through it and getting some of the radiation dose, which can cause some lower urinary tract symptoms. So either getting up at night more often, which some patients will obviously already be doing before they come to us, or flow issues where almost like a garden hose where they'll be struggling to empty their bladder. At the same time, these patients will normally have androgen deprivation therapy, so either an implant or an injection, and they'll normally start, once they're diagnosed with a tablet form, for about sometimes up to 1 month, 2 months, 3 months, and then they'll come for radiotherapy afterwards. And I think they do really struggle with those side effects. That's something else completely, where they might have lots of tiredness, maybe mood swings, can get gynecomastia as well, but also the sexual dysfunction side of things, which for this patient was a big thing. He was very upset that he always had to say that it really didn't work anymore. The erectile dysfunction side of things, I think it can hit you almost instantly from the hormone treatment, and then while we attack the prostate area, it can really almost destroy their sex life during treatment and sometimes beyond. But there are lots of exciting people like Will, who's here today, he's looking into research around this. So there are things, obviously medications, and there are sort of pumps or even implants that can really help patients moving forward. So I think it's about having that kind of chat with them quite early on. And obviously, you can guess the emotional support for this patient was something that maybe necessarily when it comes to treatment, people don't always think about, but what he was going through, so probably PTSD, living alone, not having any support, going through a completely different change to his habits and normal routine, coming in for treatment, it was quite a big challenge. And it's something where, as my role as a treatment review radiographer, I would be his point of contact, similar to, I suppose, to a clinical nurse specialist, but through that treatment where in week 1, mid-treatment, sorry, and towards the end of treatment, I might see this chap just for a one-to-one review to talk about anything and everything, giving tips as to kind of how to manage it. So would you mind if we went to have a look at the image, please? So you obviously talked about where we're treating. So he was also a prostate node, so he did, we were prophylactically treating his prostate node. So if you could just put the dose back on, please. Thank you very much. So lots of pretty colours. There's a lot of dose going through some areas, but people like Sue will work very hard to avoid some of the sensitive structures. So although the bladder will get quite a high dose, if, and obviously our patient, he was not filling his bladder properly at all. It was always half or even not less full. So where the bowel, the light blue lines was always dropping even further down, and more of his bladder was being irradiated, at least, I mean, the first couple of weeks of treatment. I suppose, Sue, do you want to talk about where we can replan if we have to with a lower bladder volume? I know it's a bit more difficult with these type of patients.
Yeah, and it does happen quite often, and that people struggle to a point where we are asking the question. And I do quite a lot of assessments where basically we get a scan from when they're on treatment, and see what the new bladder filling is like. And every radiotherapy plan we do has what we call tolerances, which is basically how much radiation something can take before it doesn't work anymore, before it dies. And so we work within those, and the fear is that if, for example, the bowel is getting more dose, that we are exceeding that. So we have to double check ourselves if things do change, inside or outside, so if patients lose weight as well. But in something like this, the bladder for a chap like this, I wouldn't worry too much day one. So when someone comes for a planning CT and the bladder is sort of this sort of size, I sort of think, from experience, we think that he should be able to manage. Sometimes we get patients whose bladders are like a litre full, and they, when they come for their planning CT, and you just think, this isn't going to be how it is after 6 weeks, and we're going to have problems. So sometimes as well, we are getting to come back again, or to empty, and we'll do another scan, because we just want it to be as good as possible, but also reproducible as possible. That's a big radiotherapy word. So that throughout the course of the treatment, we can keep everything the same as it can be. So yeah, replanning is like nightmare scenario. It's literally drop everything, all hands on deck. Okay, who's planning it? When's the doctor going to be able to redo his bits and pieces? Who's going to be checking it? How soon can we start the patient? And it's very, very rapid, all hours sort of working scenario. So we like to avoid them if possible, and it avoids the extra stress for the patient as well. So
yeah, lots of patients, just touching on the psychological aspect, they'll think that it's their fault, but actually sometimes we find in practice we don't always give them enough advice at the right point. So obviously making every contact count. This is sort of where, as AHPs or nursing backgrounds or clinicians, is where whenever you meet a patient at any point in their pathway, even if they're coming to you in GP surgery, it's about giving them that kind of opportunity to improve their lifestyle changes. It's where prehabilitation comes in. I know, Joe, you do a lot of work in prehab, but this is where pelvic floor exercises, kind of changing to maybe to decaf, even though that still has a bit of caffeine, trying to increase the water intake so that we can have a reproducible bladder throughout treatment, basically. Joe, do you mind if we go back to the other screen and I'll go on to the next patient in a sec, please?
I will stop that share.
The last thing to say is, so I've got the squatty potty there, if you've never heard of it. So I was born and raised in India. We always had a hole in the floor. We never had a Western toilet. And yeah, that's why you don't get many patients in India who have hemorrhoids or problems like that. So squatty potty, the puborectalis muscle, which you can just about see, that wraps around the rectum. When the knees are not sort of above the waist height, that gets almost strangled. So you might find that some patients not emptying, or they come to us with constipation. On the right hand side, if they just get a little step or a squatty potty, you can get it on Amazon. It releases that muscle and you get better defecation, which is something that this patient did not want to try, but he did approve of it when it helped with his bowel movements afterwards. So yeah, next slide, please, Joe. So just thought I'd touch on head and neck patient as well, which Sue will show up in a second. So head and neck patients are obviously very complex. They can have quite long treatment, so it can be sometimes up to 7.5 weeks, and they get more than sort of 60 grays of radiation dose. Some larynxes, they might have only 55 gray in about 20 fractions. Very complex. I mean, you've got skincare problems, oral care problems, pain management, and kind of how do we, nutritional problems as well, sorry, but how do we sort of manage this from a multi-professional working? So yeah, Sue, should we have a look at the plan and then we can talk over it?
Yep.
So when, sorry, so we saw the video, the lovely young man talking about his treatment and showing you what happens with the mark, etc. So this is where Sue, I'll hand back to you. This is where Sue would be in her element, trying to figure out the treatment.
Yeah, so head and necks are, I want to say, the most complicated sort of treatment I have to plan, because there's so much going on, and because it's in such a small space as well. Everything is so confined, close together. When we talk about organs at risk, everything is there, and it's all just in one very, very small place. And where I was saying about how we have to draw around everything that is important, on the left of my screen there is a list of all of the things for someone like this, and I haven't switched them all on just because it just looks very overwhelming, but yeah, all of those things have been outlined. So if I put like his mandible on and got his teeth separately, that kind of thing. One of the most important things for head and neck patients is the spinal cord. So it sits in the spine, shielded by the bone. But again, coming back to how everything is so close together, for patients like this, it's one of the big dose limiting structures. That's what we say. And the whole principle of radiotherapy is we want to try and give as much dose to something as possible to kill the tumor, without killing all the important other things around it. Yeah, spinal cord's a big one. And for head and neck radiotherapy, we have to really shape the dose around to make sure that we're not going to be causing big problems for the spinal cord. For example, it would be paralysis, or as kind of an endpoint, or death of the spinal cord. So very important that we want to not be causing that. So everything is very well sort of measured. My work gets checked by the doctor, it gets checked by a physicist, it gets checked by sometimes a second physicist, and then it gets checked by the radiographers, all before anybody switches a linac on. That's why it all takes so long, because there's so much of that going on. Then with the other sort of organs that might sort of stop us trying to give as much dose as we want to, it comes down to maintaining normal function of things like swallowing, eating, these very important things that patients do struggle with so much when they come to radiotherapy treatment. For someone like this, the area we're treating is the red bit on the, it's our left hand side, it's his right hand side. And that means that we can hopefully spare as much of the stuff on the other side as we possibly can. So this yellow thing is one of the submandibular glands, which is a very important salivary gland. If I go up a little bit, there's a parotid gland as well, which is a big one that sits just sort of with your cheek. And these are very responsible for salivary production. So if we can spare those, we can hopefully keep them sort of eating soft foods as much as they possibly can, and still swallowing sort of 40-sip drinks and things like that, without necessarily needing to have a peg. I'm going to put the dose on because now it does sort of shows off what we're able to do with the radiotherapy techniques we have now. Is this blue line is like completely avoiding that parotid gland, so it won't be affected at all, which is great for the patient. And similarly, this salivary gland on that same side will keep going, and it's just everything on the side we're treating is essentially is in the way, and we really can't do anything about it. It's with head and neck cancers, they're often arising from those very same structures or nearby, and it's just what we need to treat essentially. In this case, the red bit in the middle was a very big mass. It was a nodal mass, so lymph node mass, and you can see there's a couple more little lymph nodes that were in there as well. But the reason I picked this case to highlight as well is to talk a little bit about what happens with weight loss. And these head and neck cancer patients sometimes are on treatment for up to 7.5 weeks. And they do lose weight. Like, I don't think I've met one who hasn't at least lost something. And so we're doing that careful assessment all the way through to see if we need to do anything different with the plan. And it does happen quite often with these cases. If they lose a lot of weight during treatment, we have to go back to the drawing board and get their sort of treatment plan started again, basically. And it is especially challenging because the clock's already started. They've already started their radiotherapy treatment. This type of cancer, head and neck cancer, is typically aggressive. It can grow quite quickly. And so we can't just press pause. So we have to just try and turn these things around as quickly as we can so that we don't extend our overall treatment time. So yeah, as I say, it's the biggest headache for us in sort of the planning department. Relish the challenge, and you know, it is great when it all comes together and we know that we've given the patient the best possible experience that we can. You know, they've lost their weight and everything. So on the right hand side is actually an example of an image that we take on the linear accelerator itself. So let me turn the dose off again. You can see hopefully that there's a difference in quality. The one on the right is quite fuzzy and grainy by comparison, so we can see things in a little less detail, but it does show us that there's definite weight loss going on because this red structure is now in air when before it was inside the patient. But the other thing that stuff like this really does show us is that we actually saw this big tumor response as well. Again, it's fuzzy, but we can see that this mass is definitely reduced too. So it's really rewarding to see what radiotherapy can do in real time, and you know, we do actually see that from time to time. We can't really say to patients, hey, yeah, it looks like your tumor shrunk. It's not our place. It's just something that that we think is happening. It's not quantified, it's not diagnostic quality, but you know, we can see that they're leaning towards a good outcome, which is really nice. Right, I'll let you carry on talking, Damon, sorry.
It's okay. I think you really highlighted how complex these patients can be. I mean, they can get side effects virtually from the first week. So that could be salivary changes, as you can see from that, difficulty swallowing, and going to touch on kind of skincare in a moment, but the nutritional side as well. So if they've had sort of a rig or a peg, you know, it's important to touch base with our dietitian colleague. So where I've worked before, when I work at the minute as well, we have a multi-professional team. So speech language therapist, therapeutic radiographer, head neck clinical nurse specialist, and a dietitian on call every Tuesday to catch up with head neck patients in a clinic, just to manage all of their side effects and see how they're going. Obviously, pain management is another big one, making sure it's soluble for larynxes, or you know, something like trying to make it more personalized to each patient. I could talk for hours about side effects, but overall, you know, side effects can occur to any patient at any treatment site, and they can start virtually from the first appointment. But also they do carry on. So we normally say side effects can continue for sometimes 2 to 14 weeks afterwards, but that doesn't mean that after the 14 weeks they stop. Some side effects can continue longer than this. If patients had chemotherapy, there's so many different factors that can affect this. And actually sometimes some patients, for example, thorax patients who've come to us with, let's say, shortness of breath or a cough, they can actually find that by the end of radiotherapy, their side effects that they presented with have got better and their lung function's better. So there's lots of different elements to how the radiotherapy works. I think it's quite interesting. The late effects, I'm not going to touch on it too much because it's a huge topic area, but they can be 3 months down the line to 20 plus years down the line. They present differently to each patient, and each site will be slightly different. But I think it's just about highlighting to your patients that sometimes these changes happen later on. Sometimes if patients, for example, have had radiotherapy treatment, then they have chemotherapy afterwards, they can have what's called a recall reaction. So where they've had treatment, let's say, for example, their breast, they might suddenly have a skin reaction in that area just after the radiotherapy when they're having the chemotherapy. So lots of different things, but at the moment, there's lots of late effect teams and clinics slowly building up across the country. If you do have any questions with any patients that you see, you know, they've had radiotherapy a long time ago or even over 3 months ago, there is with the Society College of Radiographers a late effect special interest group, which is run by some fantastic people. So just reach out to us if you don't know them already. We can link you up and just try and make that communication, I suppose, between our professionals a bit better, especially if you're in the community. Next slide, please, Joe. So I'm just going to touch on skin. So we've talked obviously about the pelvis and head, neck, and breast side effects. Prostate or gynecology patients won't necessarily see a skin reaction. Some gynae patients might, but head, neck, and breast, they do normally see quite a bad skin reaction. So this is where I get to kind of my nerd on. This is my area and I really enjoy. So skin reaction, it can occur from probably sometimes about 2 hours or so after radiotherapy. I know Joe touched on the therapeutic window, so the 6 hours after treatment. So when a patient has treatment, this kind of cell healing process will occur for the next 6 hours very quickly or very harshly for some patients. And it can start, as I said, almost straight away. So you get an inflammatory response, so that's within sort of the dermis layer. And it's very similar to the process of tanning. So for lighter skin tone patients, you'll start to see a bit of redness. So on the bottom right, just coming down, that's actually a head and neck patient where it does start to look a bit more flushed on that side. And I know it says 10 to 14 days, but it can be quicker than that for some people. And it's important to note that each cell will obviously work on a different time frame. So some cells will be, you might be able to see, in that a bit redder on the back of that patient, and where on the kind of periphery, they're not as red. The new cells are constantly kind of evolving and reproducing, along with the old cells being flushed out. And moving up to the top left, we don't normally see some of these skin reactions that bad anymore. So there are a few different grading scales, which I'll come on to in a second, but sometimes you might see that for some head and neck cancer patients, around their neck region, they do have a quite almost like moist desquamation, to where it can look a bit fluffy, or lots of exudates coming out. It's quite normal for this to happen, but for some patients it's worse in the next couple of weeks after radiotherapy finishes. So we do normally tell them to keep in contact with us and come back. But if they present to you in your clinics or whatever, just speak to your radiotherapy team. There'll be a review radiographer or someone who's able to sort of manage these kind of side effects. I suppose when it comes to this sort of thing, the treatment radiographers will see the patients every day, and they'll normally do an assessment of some sort. We'll monitor it, and there's always dressings and creams and everything. So lots that I could talk about, but I'm just gonna leave it as a. Sorry, I should have said there are some graphic images of skin reactions. I'm sorry for eating your dinner. On the left is an example of that, what's called the RTOG, so the radiotherapy oncology group scale. I've actually never said that out loud. So yeah, RTOG. Lots of different kind of levels as to how skin reaction can happen. So on the right, it just shows you how deep the skin reaction can go within the skin. We don't like to call it a burn, because there isn't really a kind of a central layer of necrosis, and it's not that the skin is almost melting away underneath. It's kind of on the epidermis and goes into the dermis. It doesn't normally go any further than that. So as you can see, skin reactions develop and can look very different on all types of patients. I think it's important to note that some of these grading tools, if you've come across them, they talk about the skin reaction as just being redness. So my big passion at the moment is trying to make skincare more inclusive, where redness on a very dark skin patient is not going to show up. It's just not how it works in any dermatology field. So the terminology is obviously very important for our patients, because if you're just looking for redness on a dark skin patient, you're going to miss it. So you can see on the top left, that's obviously a scar. It was, I think, a chest wall patient. So you can just see a bit of a faint tan. And this is actually about 2 weeks post radiotherapy. So some light skin tone patients will have a bit of erythema, redness, so skin reaction, and you can see a prominent almost rectangle where we've treated, but that will continue for 2 or 3 weeks afterwards, and then it will become a tan. So it's all to do with melanin production within the skin, and that for lighter skin tones, it develops as redness first, and then you get a tan, similar to when you go on holiday. For people like me, or for darker skin patients, it actually looks really dark first, and then it might break down, or it might get a bit more swollen. So just different things to look out for. Excuse me. So on top right, you can see some of those red patches. This is one with skin cancer, where it looks a bit darker before it becomes before it becomes more of a serious skin reaction. The bottom right, there's a few harsher reactions where you can see that the ones with the arrows. Sorry, that's from a journal that I stole, but they have kind of pointed out kind of where the main area of the radiotherapy is, but on the edges you can see how skin heals slightly differently. So some bits are healing quicker than others. That's why skin flakes, and it's completely normal. We all flake skin off every day. On the bottom kind of middle left is a breast patient. This is where I think skin kind of assessment is really difficult, because some patients will have different types of reactions. So if you look on the left with the scale, like the RTOG 1, 2, 2.5, 3, 4, I mean, this patient has almost 3 different skin reactions in one, so it's quite difficult to grade it and obviously pass it on to anybody else who might assess this patient in the clinic further down the line. I think it's just important to kind of almost break it down into sections. So their IMS is this, around the areola it's this. That's kind of how I would do it. So the bottom right is just an example of kind of why I'm quite passionate about the skincare area. That we had a head and neck patient, very dark skinned head and neck patient. Normally towards the end of their treatment, they will have quite a serious skin reaction, and it's quite normal. But because my colleagues at the time had been looking for kind of redness, it wasn't always going to show up on their dark skin. And because of that, we sent them home. The next day when they came back and they had a bad reaction, which looked like this on the bottom right. I think it's just important to, if you see a patient maybe a week or 2 or a month after radiotherapy and they have something like this, just get in touch with us. Don't put things like pseudocreme or anything like that on. Just try and reach out to us so that we can try and help with it. Thanks, Jay.
Okay, so we're getting towards the end of our webinar. Thank you so much to everyone who's asked questions. I apologise. I know Will got inundated with questions personally. Hopefully now everyone can see questions. So continue to use that chat function. Lasting impressions from the webinar and what we kind of want you to take away is essentially knowing how radiotherapy works. As I've said, please do revisit the podcast. It's great for you to be able to maybe get your nerd on and listen more about some of the radiobiology and what it is that we're doing at a cellular level. It isn't an easy treatment, so we use patient voice a lot on the podcast to try and develop practice. So we know that consultants, if anyone follows Dr. Liz O'Riordan, she's a breast surgeon, and she said she used to consent patients for radiotherapy, and she would say, oh, don't worry about radiotherapy, it's just like having an x-ray, you'll be absolutely fine. And then unfortunately she got breast cancer and she had radiotherapy, and she said actually for her it was the hardest part of her cancer pathway. So it is a difficult treatment. Every patient has to have person-centered care, and it is really imperative that we do this, but collaboratively working together as an MDT. Side effects, as Naaman has touched upon, can happen straight away all the way up to 20 plus years, and we will definitely be doing a late effects webinar. It's something that we're really passionate about, and we have some amazing experts in the field, including Will, so hopefully we'll get him back and he'll be able to again share all of his learning and his research. Thinking about making every contact count. So we know that patients come into contact with healthcare professionals consistently, not just nurses, not just doctors, you know, lots of AHPs, lots of healthcare scientists, all the way through their pathway. And I think us having knowledge of each other's role and the information that we can essentially disseminate between each other, I think is really important. And I think one of the last things is asking questions. So if I'm struggling with a patient, or essentially if I've got a student who has witnessed something in clinical and they say, oh, I wasn't quite sure on what to advise, I would very often say, well, why don't you ask the dietitian? Why don't you ask the speech and language therapist? And I think it's so important that we start to break down some of these professional barriers and learn from each other. Learning with, from and about each other is something that I am hugely passionate about, but purely because I know that I have huge gaps in my knowledge, and I need to ask different people to ensure that I'm supporting patients, but also educating the future workforce correctly. So I'd like to end by saying a huge thank you. We've absolutely loved talking about radiotherapy. It's obviously what we're all really passionate about, but we would love to get some feedback. So I know Tara and Will are going to share the evaluation in the chat function. So please do take some time to just evaluate us. The reason for this is obviously we do this all in our spare time, and it's important to make sure that we're hitting what people want and what they need, but also thinking about other webinars that we might want to put on. If you are an expert in your field and you think actually this would be great to do a webinar, I know I think it was Kirsty in the chat function said it would be great to kind of link up. Absolutely, let's do a webinar on it. Let's get some of these collaborations going so that we can start to work synergistically with each other so that we can help support patients along the pathway. If you do want to get involved, want to do a TikTok video, if you want to create some Instagram posts for us that we can share, you know, we're really passionate about making sure that we're advocating for all of the healthcare professionals along the oncology pathway. So drop us a DM, drop us an email, however you want to get in contact with us is absolutely fine, but it would be great to collaborate with people and hopefully improve care and also ensure that we're providing the best that we possibly can for our patients. So a huge thank you again to Naaman, Tara, Sue and Will for contributing. We will send out this recording, so feel free to disseminate amongst your peers if you feel it's worthwhile. And hopefully we'll see you at the next webinar. Thank you so much, everyone, and good night. Thank you.
Thank you.
Thank you.